All right. Again, I don't have anything to disclose regarding this device other than I believe in it. As you know, EVAR has a number of unmet clinical needs. Basically, there's a high rate of secondary interventions. We'll talk about that in a minute. Most are related to type 2 endoleaks, migration, and some problems with limb occlusion. Most are all related to challenging anatomies and aneurysm stability, regression, and surveillance requirements are high because you need to be, if there's an endoleak present, you've got to surveil these people to make sure that you're not getting sac enlargement associated with it. You look at the EVAR rates of secondary intervention, the average in a whole number of series, both RCTs and case-controlled studies, averaged out at about 3 years at 18%. And again, if you look at Manish Mehta's data, he had a 19% secondary intervention rate at 34 months, most of which were related to type 2 endoleaks, more type 1 and type 3 endoleaks. You look at the data for cost in the United States, at least, for dealing with these problems. Endoleak is 5 times as much for surveillance, 10 times as much if you have to do a secondary intervention. Greenall and his associates showed, they analyzed the long-term results from EVAR 1 and 2, showed there were 22 late ruptures, and of those, 17 were related to sac expansion and an endoleak, and statistically significant. If you have those things, you're going to get into trouble if you don't fix it. Device manufacturer's challenge has been to minimize or eliminate endoleaks, improve the device conformability to the patient's anatomy, develop innovative means for endograft stabilization and techniques for preserving blood flow. This is what they've done. They've developed a whole bunch of devices which look just like the devices we have now. They spent millions of dollars on this, and they still have none of these devices address in any way the problem of type 2 endoleak, which is the thing, if you do a lot of these cases, as we have, is what drives you nuts, because you can never get rid of the type 2 endoleaks. You treat them, they go away, then they come back, and it's an ongoing problem which is expensive to deal with.
Cliff, we give you 2 more minutes because of the problem when you change.
All right, that's
okay?
fine.
2 more minutes.
Okay. The endovascular sac sealing concept, I really give these folks a lot of credit for this. This was outside the box thinking. They addressed the problem of endoleak in a very unusual manner, and I give them great credit for this. And what they've done is developed basically endografting for idiots, because if you can pass a guide wire from a groin to the level of the renal vessels from each groin, you can definitely deploy this device and treat the patient's aneurysm. It's a low-profile, flexible system. It uses existing anatomy for fixation. It's called endovascular sac sealing. That's what it is. 2 cobalt chromium balloon expandable stents, and I'll just take you through this for a moment here. These are the access wires coming up from the groin, and I'll show you the components in a minute, and and there's a little cartoon that makes it all very clear. But that's the sequence of deployment. These are the components. In the upper left is the cobalt chromium stent. It's 8 millimeters. It's surrounded by a PTFE coating. Right below that is the endobag. There's one around each one of those cobalt chromium stents, and that's what's filled with the polymer, which is in the right upper side of the screen. This is a polyethylene glycol diacrylate. It gets to the consistency of a pencil eraser or heavy or firm jello. And the control panel is how you deploy all this stuff. You go step 1, step 2, step 3, step 4. It's numbered, and even vascular surgeons can figure this out. The interventional radiologists and the cardiologists don't have any trouble with it, but the vascular surgeons, they had to number everything so we could get it right. This is the cartoon. This shows you exactly how this works, and I think if you see this, you'll get the whole idea of how unique this concept is. That's the endobag being deployed. Look at the inset cartoon. That's the bag each bag being filled with polymer around the 2 central stents for years, and you can see the polymer is still pristine. There's no deterioration of the polymer. It retains its shape, looks just fine. And if you look at the timeline for studies, 2006, 2008, they cheap implants, they sacrificed them all at 4 years, looked at the polymer, looked at what its effect was on the aneurysm, and then the pilot study started in humans, and they did, I think it was 34 patients which were submitted, and they got the CE mark in Europe, and now they're going to start and have, I believe, have approval to start sometime in the 3rd quarter of this year in the United States, an FDA IDE trial, which will enroll 150 patients. Just a little bit of summary of what they found. In the initial study for the CE mark, there was 1 type 1A, 1 type 1B endoleak. Both of these were related entirely to device deficiencies. The original device in its first generation was very difficult to use, and it had some drawbacks in terms of how these endobags deployed. Neither of these were of any consequence, and I'll show you pictures of what they were. The second follow-up, 35 patients, there were only 2 type 2 endoleaks. They were less than 1 centimeter or 1 milliliter each. It was because the endobag was just slightly smaller than the cavity it was filling, and so there were 2, they all went on to thrombose within 6 months. This is the type 1A from the original device, original series, and you see what it is actually the lower left-hand corner. You'll see at 30 days, the arrow is pointing to a cul-de-sac. That's really, the endobag just didn't go high enough in the sac. There was a little cul-de-sac, it was blind, it didn't fill from anything other than forward flow. It thrombosed and it was gone in a year. The iliac lesion on the other side, unfortunately, had to have an insert put in, a limb from another endograft, because the middle sacral artery filled an area where the endobag did not reach. This is just a standard case, 6.5 centimeter aneurysm, treated with the Nelix device. And look at across the bottom, 1 month, 6 months, 12 months, 24 months. The study, the same patient is followed out actually to 36 months now. And those limbs, you see nothing moves, nothing moves. Absolutely stable. If you look at this, you'll see there's 2 blue arrows on the left-hand side. One is to a patent IMA, the other is to a patent lumbar vessel. This is a real setup for endoleak. If you do a standard modular device or any of the current existing devices with large IMA and a large lumbar right behind it, you're set up for a type 2 endoleak. When you put the Nelix system in here, the IMA is occluded right at its orifice, the lumbar is occluded, and there's no endoleak filling. So again, the final design, 150 subjects would be the FDA ID program in the United States. EVAS-2 will be a post-market study in Europe, 200 subjects, multi-center registry. Maybe some of those will be included from the US if it goes on long enough to find that many patients. I'm very excited about this device. I think when you all get to see it and use it, and it will be not long before it is out and available. Matt Thompson in England treated 5 aneurysms between 8 o'clock in the morning and 1:30 in the afternoon using this device, and went home at 3. Just so, I mean, it is really and truly a giant step forward in treatment of aneurysm disease, and so far, it does not appear to have any significant drawbacks. Thank you.
Thank you, Professor Buckley. Can you stay on the podium, because I have a question for you. We can feel your passion for this second system, and it's so interesting that I would like to ask you if the system, the sac sealing EVA system that you described during your second presentation is reserved only for extreme case, or do you plan to go to more common case in the future?
I'd use it on everybody I was going to treat for an aneurysm. I mean, why put up with the possibility of developing a type 2 endoleak that drives you crazy? Those people who, I mean, we put in probably 1,200 endografts in our group, okay, between 2 hospitals since 2000. And I will tell you that the thing that drives me crazy are the people who come back with type 2 endoleaks and a couple of millimeter diameter sac enlargement. Then you have to go put them through the drill, try to find it, try to fix it. And fixing it is not permanent. That's the problem. You get in there, you put coils, you put, and these things are not cheap. The coils, are $1,500 a coil, sometimes more than that. You put the coils in, you put glue in, and then everything's fine, looks great. You tell the patient you're doing good, stop worrying. You know, patients think they have a leak. You know, they think the leak is like a boat sinking, so they worry about it. So then they come back and you say everything's fine. Then the next CT scan you get, there's a type 2 endoleak in the same area, back again, because it doesn't solve the problem. And so I would be more than happy to have a device that I could put in that I don't have to worry about that.
You seem to be a very ardent supporter. I have a complementary question for you. Is there any kind of learning curve And by the way, did you encounter any problem in the sac filling?
I have not encountered any problems with the sac filling, and I don't know that they've had any. One of the questions that people have asked, what happens if the sac gets a leak in it? Supposing you go to pressurize the sac. Sac is pressurized to 180 millimeters of mercury. So, okay, what happens if you get a leak in the sac? Well, you stop. And in 3 minutes, the polymer is cured, the hole is sealed, and then you go on and just keep going. Okay, and they've done that in animals to show that that's what you do if you had. They have not had any leaks in any of the humans, but you know, who knows, you could probably get a calcium spicule or something that might tear the bag or poke a hole in it when you're deploying it. I think it's going to be a real game changer. I don't own any stock in this. I wish I did, but I don't. I don't talk about or represent devices that I own any interest in. But if I could, I would have bought stock.
Cliff, since people seem very interested in these talks regarding the first system,
yeah.
the Ventana, do you think this could replace the usual fenestrated graft that we used to have available in a recent past? I don't give the name of the graft, but the one who are designed with fenestration. Do they intend to replace this a little bit artisanal system?
Well, it's hard to, I think they do tend to, that is a competitor for that system. I'm not sure I know exactly what the issues are with the Ventana. The company very wisely stepped in. They said they weren't happy with the some of the renal issues, and so they decided to halt their FDA IDE voluntarily. I think that was wise on their part. They are going to undergo, I talked to John McDermott, who owns the company, said that they're going to undergo a complete root cause evaluation of the whole system to make sure that there's not some issue that they really need to address.
And I have a final question, but a short answer. When this product could be available in India?
Which one? Nelix?
Both.
Well, Nelix, I guess, could be available in India whenever I don't know what your rules are for bringing things in. It has a CE mark in Europe. It just got it this spring. So if it has a European CE mark, maybe you can have it in this country. If you have to wait for the FDA IDE trial, it'll be 2 years from this fall, because they want a year's follow-up on the patients before they'll give you tentative clearance to start putting it in outside.
But Cliff, hope makes life better. Hope, the hope makes life better.
Yes.
Thank you, Professor Buckley.
I've got a question, Jack.
Oh,
I've been
the
waiting
last.
for you to. Now, I've got a simple question for you, Dr. Buckley.
Yeah,
Now, you have got a patient with thoracoabdominal aneurysm,
yeah.
and you are very fortunate to have two devices on the shelf. One is MFM, one is the Ventana. Which one you are going to use?
Oh, I'm going to give you my philosophical answer to this question, okay? And it takes a couple of seconds, so,
Short.
but I'm going to give it to you. I'm going to do it quickly. There's a mathematician who at Texas A&M University that I'm affiliated with. He's a doctorate in mathematics and fluid dynamics. And he says that if you put a device inside an aneurysm that has a different compliance than the aneurysm wall, this is just anything in there, that you alter that formula that says what puts tension on the wall that ultimately causes disruption of the aneurysm. In addition, Monsieur Henry knows, and so does Professor Benjoulin, that when you put this device inside the aneurysm and you convert turbulent flow to laminar flow, it's the turbulent flow, the small forces of the turbulent flow are what disrupt collagen and elastin fibers in the wall and cause the aneurysm to go on and rupture. So when you convert that to laminar flow, you are relieving that pressure, and the finite analysis studies show that the stress factor on the wall goes away when you put this device in there. So let me go one more minute. Okay, then. So here's what I say. Most of these people who have thoracoabdominal aneurysms, most of them, die in 5 or 6 years of their comorbidities, their heart disease, their kidney disease, their obstructive lung disease. And so if you can give them something that will temporize their aneurysm from rupture till they die of some other cause, what difference does it make if it's perfect or not? And this is pretty simple. I mean, this is, you know, put it in, deploy it, go home. It's not standing, have you ever done any of these branched endographs, thoracoabdominators? Done a couple. I was in the OR 9 hours, 3 hours of fluoro. 3 hours of fluoro time over 9 hours.
And
When I went home, I glowed in the dark for 2 days.
And still alive.
Okay.
You know, Professor Berkeley, we understand your answer.